Good afternoon, everyone, and thank you for spending the time today to join us on a very exciting afternoon on the discussion of familial hyperlipidemia. It gives me great pleasure to introduce a distinguished panel of speakers for today. And my name is Natalie Koh, and I'm a cardiologist, a consultant cardiologist at the National Heart Centre in Singapore. My clinical interests are in cardiometabolic disease as well as non-invasive multimodal imaging. And I've worked closely with the panel members today. Let me introduce our chair for the session, Professor Tavintharan Subramaniam. We will certainly hear more about his distinguished CV as he gives the second talk today. I would love to introduce our first speaker after some housekeeping rules. Please note on screen how we should be utilizing the chat box if you have any Q&A questions for the panel, which we will address after the completion of the 3 talks today. So for our first talk today, we have Professor Tai E Shyong. Professor Tai is going to talk to us today about a population health approach and the role of genetic testing in familial hyperlipidemia. He is going to give us the foundations upon which we will discuss even more complex issues. Professor Tai went to medical school in Scotland at the University of Dundee. He subsequently returned to Singapore and trained as an endocrinologist at the Singapore General Hospital before moving to the Yong Lu Lin School of Medicine and the National University Hospital in 2009. At NUH, he served as the head of the Division of Endocrinology from 2010 to 2015. Currently, he is the director of the Center for Precision Health and the Center of Excellence for Chronic Disease Prevention and Management in the NUHS, where his role is to bring innovation to the treatment and prevention of disease in our population. Professor Tai, please.
Thank you for asking me to speak at this symposium this afternoon. My name is E Shyong, and I'm from the Division of Endocrinology at the National University Hospital in Singapore. I've been asked today to speak about a population health approach to familial hypercholesterolemia. And specifically, I've been asked to examine the role of genetic testing in this approach. Here are my disclosures. I have served as a member of advisory boards for Novartis, and I've also been the recipient of an educational grant from AstraZeneca to study the implementation of clinical pathways for familial hypercholesterolemia. I think it's important whenever we try and come up with an approach to a problem that we first understand what the problem is. So let me just start by reminding all of us that familial hypercholesterolemia is a disorder that is characterized by extremely elevated levels of LDL cholesterol and an increased risk of premature heart disease. It is an inherited condition and is inherited in an autosomal dominant manner and is usually due to mutations in one of 3 genes, the LDL receptor, apolipoprotein B, or PCSK9. In most populations, it has a prevalence of about 1 in 250 to 1 in 350, making this one of the most common inherited disorders in the world. And based on these numbers, we estimate that in Singapore alone, which is a relatively small country, we have approximately 20,000 people who suffer from this condition. Most of them are not diagnosed, and this is important for the following reason. The first is this. These individuals, as I've already pointed out, are extremely high risk of cardiovascular disease. So you can see that patients with high cholesterol due to familial hypercholesterolemia are actually at up to 25 to 26-fold increased risk compared to people who don't have hyperlipidemia in the general population. The second thing that is worth pointing out is the following. Even amongst individuals with very similar levels of cholesterol, individuals who carry mutations that cause FH are about 6-fold more likely to develop cardiovascular disease than individuals who do not carry these mutations. Why is this? I think it reflects the duration of exposure to high cholesterol. I think that if you have familial hypercholesterolemia and you're born with high cholesterol, by the time you're 20 to 30, you have been exposed to this high cholesterol for several decades. And in fact, that's why we often see patients with familial hypercholesterolemia develop coronary artery disease in the 3rd or 4th decade of life. In contrast, individuals who have high cholesterol for other reasons, particularly if these are environmental influences, tend to develop high cholesterol much later in life. And so by the time they had the same 20 or 30 years exposure to high cholesterol, they're in their 60s and 70s, which is why the median age for the first myocardial infarction in Singapore is about 60 to 65. This is important because what we're really trying to find is a group of individuals who have high risk despite their levels of high cholesterol. It also tells us that if you use cholesterol alone to stratify risk, you will underestimate the risk in these individuals, and as a consequence of which you may undertreat them. The second thing that I think is really important is not only is the risk high, it is treatable. If you give these individuals statins, and I'm showing you data now from the Dutch Familial Hypercholesterolemia Registry, if you give them statins, you can return them to a life expectancy and coronary heart disease event-free survival that is almost the same as individuals who do not have familial hypercholesterolemia. So this is particularly pertinent because, as I've said, most of these individuals are undetected. Having said that, it makes a difference when you start. In this figure, and this is hypothetical, what we're showing you is cumulative LDL cholesterol. So this is the level of cholesterol times the duration that you're exposed to it. We think that this is a better measure of exposure and a better measure of the risk of cardiovascular disease. So in this example, can imagine that there's an arbitrary threshold. And when you've accumulated a certain amount of exposure to cholesterol, you get heart disease. You can see individuals here who are normal, as I said, their high cholesterol develops later in life. And in fact, they don't get heart disease until their 50s, 60s, and 70s. On the other hand, individuals with familial hypercholesterolemia are exposed to high cholesterol from the day they're born. And in fact, many of them will develop heart disease in the third or fourth decade. And it's even worse for individuals with homozygous familial hypercholesterolemia. This has several implications. If you don't start screening for high cholesterol in the population until the age of 40, as we do in Singapore, you can see that in fact these individuals won't get diagnosed until they have crossed this threshold. And very often they will already have heart disease by the time they are diagnosed. And that means that you've missed your opportunity for prevention. But there's another implication. And the other implication is that we don't seem to be able to reverse the process of atherosclerosis. In fact, the best we can do is sort of slow it down. Now, if you start treatment in the early teens, as they do in Holland, over time, over a lifetime, you can return these individuals to a level of risk that is very similar to individuals who do not have familial hypercholesterolemia. On the other hand, if you start later, the benefit is smaller. And if you don't start until you're about 40, the benefit is even smaller. So I think, if I may summarize, that familial hypercholesterolemia is common and that treatment is effective, and that's why we need to pay attention to it. I think that if you screen by lipid testing, this has a number of consequences. The first is that it results in the identification of individuals late in life, when treatment is often too late because they already have heart disease, or the effect is much smaller. And actually, because the LDL cholesterol that doesn't take into account the duration of exposure systematically underestimates the risk of coronary artery disease in these patients, they are often undertreated. So the problem we're trying to solve is the following. How do we identify individuals with familial hypercholesterolemia at a sufficiently early age so they can be treated aggressively and live long, happy lives? I'm going to show you a couple of examples and think about different approaches that we can take. The first is this. So there are about, 900 of these little figures on this graph, right? And within them, there are 3 individuals in red who have familial hypercholesterolemia. That's about 1 in 300, which is the prevalence that we expect. And as I've already shared with you, if you don't do anything, any genetic testing or don't do anything special, and you wait until people are 40 years old before you start screening them using lipids, not only will you pick them up too late to do anything, many of them will already have heart disease before you even make the diagnosis. And that's what this picture depicts here. There are a number of options for doing this. One option, obviously, is that genetic testing is becoming very cheap. You can do this in many, many people. Why not just test everybody at the time they're born or when they're in childhood? And you could do that. You could sequence LDL receptor, apolipoprotein B, and PCSK9 in everybody, and you will identify these three individuals relatively quickly. You could get them young, but it's expensive. And you will have to test somewhere between 250 and 350 individuals to find one case. And you'd have to test the whole population to find the 20,000 that we're talking about. Having said that, if you are able to make this diagnosis, you can treat them early and give them long, healthy lives. The nice thing about familial hypercholesterolemia is that it is familial. So these 3 or 4 affected individuals are not scattered randomly throughout the population. In fact, they do cluster, and they cluster in families. And what you see here in this figure is a father and his child who has familial hypercholesterolemia, and a mother and her child who have familial hypercholesterolemia. And very often you'll find that these two are relatives of each other. So they may be brothers and sisters or cousins. And it turns out that if you find one of these individuals, you can do a genetic test. And if they are mutation positive, you can then screen their other first-degree relatives and the first-degree relatives of other mutation-positive individuals and gradually get to these individuals. This is what we call cascade screening, and it has been shown to be cost-effective in many populations where it's been attempted. And if you think about it, the reason it's effective is the following. If you use Dutch Lipid Clinic criteria or the Simon-Broom criteria to evaluate the probability that an individual has familial hypercholesterolemia, and you take individuals with possible FH, somewhere in the region of 1 in 4 or 1 in 5 of them will actually carry a mutation. What this means is that you only have to test 4 or 5 individuals to find the case, as opposed to 250 to 350. In the instance of a mutation-positive individual, if you start to screen the first-degree relatives, because this is autosomal dominant, you will find that one of 2 first-degree relatives of mutation carriers will be positive. So this is an extremely efficient way to find individuals with familial hypercholesterolemia. And actually, when we run clinics for familial hypercholesterolemia, it's actually quite good fun, because in the end, you're not just treating an individual, you're treating an entire family. And what you'll find as you identify these individuals is that you create this opportunity for families to live happily ever after, rather than just single individuals. And I think this is really powerful and really important. In fact, this is the reason why various authorities, and I'm just showing you the nice guidelines from the UK, actually recommend that as a quality measure, patients with familial hypercholesterolemia should be offered DNA testing as part of their assessment. And that is important because the moment you confirm the diagnosis genetically, you can actually begin to screen affected and unaffected relatives through cascade testing. In order to do this, you need to have health systems that would enable this to happen. So I'll just show you the one that we built within the National University Health System. So we routinely work with our colleagues in primary care to screen the electronic medical record databases for high-risk patients. We have them referred to the Familial Hypercholesterolemia Clinic, where we score them using both the Simon-Broom and the Dutch Lipid Clinic criteria. Initially, we use very high thresholds, and we know that this will miss most people with familial hypercholesterolemia. But that's okay, because what we then do is we sequence these individuals who have possible, probable, or definite FH under either of these criteria. They undergo genetic testing, and if they're mutation positive, we then reach back into the population, into their families, to cascade screen them, so that we can find other people who are related to them who have this disease. We can initiate treatment, and eventually, when they're stable, we hand them back to our primary care colleagues. If they're mutation negative, we hand them back to our primary care colleagues, and they undergo treatment as per current clinical practice guidelines. And in fact, doing this, we've actually been able to identify 30 to 50 individuals out of almost 100 that we've treated, that we've assessed in the FH clinic in the last 1 year since we began this process. So this is my final slide. In summary, the problem that we're trying to solve is to answer this question. How do we identify individuals with familial hypercholesterolemia at a sufficiently early age so they can be treated aggressively and live long, happy lives? And I'm going to suggest to you that one possible solution you should consider is that you should be conducting genetic testing followed by cascade screening. This is cost effective and it is a useful way of identifying these individuals without testing large numbers in the population to identify the 1 in 250 to 1 in 350 who are affected. Thank you.
Thank you so much, Prof. Tai, for that illuminating talk. We will now introduce Associate Professor Tavintharan Subramaniam. Professor Tavin is a senior consultant with a dual specialty in internal medicine and endocrinology. He is the director of the Diabetes Center in Admiralty Medical Center in Yishun Health with a subspecialty interest in lipidology. He obtained a Master's of Clinical Investigation from the National University of Singapore with research interests in the study of molecular markers to predict and understand the pathogenesis of common metabolic disorders. He is the current national lead for Singapore in the European Atherosclerosis Society FH Study Collaborative and also leads FH Care, a team of researchers and clinicians from endocrinology and cardiology in Singapore, aiming to reduce underdiagnosis and undertreatment in familial hypercholesterolemia. Today, we have the privilege of hearing from Professor Tavin about the findings from the FH Care Registry in Singapore to date. Professor Tavin, please.
A very good afternoon to all of you. I would like to start first by thanking the organizing committee of the APSC for inviting me and giving me this opportunity to share with you on the FH Care Registry in Singapore. Before we go there, let us just remind ourselves on what FH is all about. Familial hypercholesterolemia, or FH, is the most common autosomal dominant genetic disease characterized by very high levels of LDL cholesterol. It has a prevalence of roughly around 1 in every 200 to 300 people in the general population. And this is associated with an increased risk of premature cardiovascular disease, both in men and women, and both as a primary event as well as recurrent cardiovascular disease, recurrent events of cardiovascular disease. The diagnosis of familial hypercholesterolemia can be made clinically, and two commonly used diagnostic criteria include the Simon-Broom criteria as well as the Dutch Lipid Clinic Network criteria. This slide shows that of the original Simon-Broom criteria. The major requirement to make a diagnosis of FH is that of an elevated LDL cholesterol level. In adults, the level is more than 4.9, and in children, the level is taken as more than 4.0. To make a diagnosis of definite FH, there is a requirement for the presence of FH-causing mutations detected. In the original criteria for Simon-Broom, the presence of xanthomas were also used for defining definite FH. Possible FH is defined as by the presence of high LDLs together with a positive family history of premature myocardial infarctions or a family history of elevated cholesterol levels. The Simon-Broom criteria was later modified, and in that modified Simon-Broom criteria, the presence of xanthomas alone was downgraded from definite to probable FH, as can be seen in the next slide here. Here you can see a new category called probable FH in the modified Simon-Broom, and this includes this is with those with high cholesterol plus the presence of xanthomas. The definition for definite and possible FH remains the same. The Dutch Lipid Clinic Network criteria is shown in this slide here, and essentially the criteria includes 5 different categories of information, including family history, personal history, physical examination, LDL, and genetic testing. What you can see is that as in the Dutch criteria, there is also, they give credit for the personal clinical history, but in the Simon-Broom criteria, no points are given for the presence of positive family history. Each of the criteria is given a score and a tally and tallied at the end. A score of more than 8 is used to define definite FH, and a score of more than 5 is that of at least probable FH, and most institutions will use the score of more than 5 as a criteria to prompt for genetic testing. The presence of a positive mutation from genetic testing will prompt the need for genetic testing amongst first-degree relatives, and this is what we use in what we call cascade testing. With that background, let's come to Singapore. This is a map of Singapore. And Singapore is a small city-state in our country. Our country's area is less than 730 square kilometers, and within that, less than nearly 6 million people live. If we look at the resident population, which includes citizens and permanent residents, there are about 4 million people. We generally have small household size of less than 4 persons in each household. And if you look at the map again here, this map shows the different 3 healthcare clusters which look after the public healthcare system in Singapore. On the west of this map of Singapore, you can see the National University Health System looking after the public system in the west. And that's where our first speaker, Professor Tai E Shyong, comes from. Right in the middle, north and north central region is covered by the National Healthcare Group, from which I come from. And the east as well as the south central part of Singapore is the SingHealth cluster, from which the moderator for our session, Dr. Natalie, comes from. So overall, if the prevalence of FH is 1 in every 2 to 300, we would estimate that there are about nearly 22,000 people with FH in our resident population. Do you know the number of people who of this 22,000 who we know have FH? The problem with FH is that there is a high level of underdiagnosis in FH. And this is work published in 2013 by Moderator et al. And on this side of the slide, it shows the estimated number of people with FH in different countries. And on this side, it shows the percentage who have already been diagnosed. You can see the Dutch doing very well, at 71% of the estimated FH have already been diagnosed. But there are countries with less than 1% of those who have supposed to have FH being diagnosed. And in 2013, Singapore was also in this category. But since 2016, we have tried to do some things and some work here to improve. And we have so far identified about nearly 800 odd individuals with FH. And that would mean that we have identified somewhere between 4 to 6% of our estimated people who have FH actually. How did we do that? A number of clinicians, doctors, cardiologists, as well as endocrinologists came together in 2016 and pledged to try to do more for FH. And that's how we set up this informal group called FH Care. And that stands for Familial Hypercholesterolemia, Case Identification, Assessment, and Reduction in Adverse Events. This is our logo for FH Care. And as I mentioned, it is a group of clinicians and researchers coming together from all the different public restructured hospitals as well as the polyclinics in Singapore. We are supported by grants from the research grant from the Alexandra Health Fund, funds the genetic testing research that we have been doing. The Singapore Heart Foundation helps to support our efforts in Cascade Testing, and Amgen has been supporting our efforts in the registry building. And we are also closely collaborating with the EAS in the work on the FH study collaborative. The key objective of FH care is to reduce the number of people with FH from developing premature atherosclerotic cardiovascular disease. To achieve this goal, we need to do at least two areas of work. One is to improve the detection of FH, and number two is to optimize the treatment of FH so that more people can achieve the LDL goals that we have aimed for in FH, that are required in FH. This slide depicts the workflow that we have as part of our FH care on how people get referred into our program and the genetic testing that is done for those who are enrolled, and how the results are returned to them, and cascade testing being done for them as well. So far, we had 614 people with clinical FH referred to us. In this slide, I call them the probands. Of them, we had 12 of these probands had severe disease, either homozygous or compound heterozygous. Nearly 200 were heterozygous in the probands, and more than half of our patients had no mutations diagnosed. We also proceeded on to do cascade testing for the family members, and the data for that is tabulated here. Of the 614 individuals, 4 of them were excluded from the analysis that follows, because one had an LDL receptor adapter protein mutation, and 3 of them had cytosterolemia, so we excluded them. Of the 610, you can see I categorized them according to the absence of mutation and the presence of mutation, LDL receptor mutation, or ApoB defective mutations as well. You can see that compared to those without mutations, those with LDL receptor mutations are younger in age. And if you look at the sector in yellow, this is we plowed through their case notes, case records, and identified the highest LDL lipid profiles recorded in them. And you can see the LDL receptor mutation patients had the highest mean LDL levels. And the sector in green depicts the area, the lipid profiles at the point of enrollment into our FH care. And again, quite a large proportion of them were already on some treatment at the point of enrollment. And you can see the LDL levels of roughly nearly 5 for those with LDL receptor mutation at enrollment. Compared to those with LDL receptor mutation, those without any mutations were more likely to have diabetes and a higher HbA1c level as well, and also other features of the metabolic syndrome, including obesity as well as hypertension in those without the mutations. They also had higher triglyceride levels, as you would have noticed from the earlier slide. This slide shows the medications that our patients were on at the point of enrollment into our registry. Nearly 80% of our patients were on some form of lipid modifying medications. High intensity statin was used in about 40 to 60% of our patients. Ezetimibe used another 20 to 40% of our patients. PCSK9 inhibitors used in less than 6% of our patients. As to how many percent of our patients had achieved the targets, lipid targets at the point of enrollment into our program, we define that as at least 50% LDL-C lowering from baseline and reaching an LDL-C goal according to their CV risk. That is to say, less than 1.8 we used in 2016, 1.8 for those with existing cardiovascular disease, and less than 2.6 in those without existing cardiovascular disease. And only 2 patients had a 50% reduction from baseline, and 4 patients achieved an LDL of less than 1.8, and 2 without CV disease achieved an LDL of less than 2.6. So very low numbers of achievement of goal at the point of enrollment. After about 6 months into our registry, you can see that the percentage of who achieved 50% LDL lowering was increased to about 25%. In terms of goal achievement, absolute goal achievement, only 5% of our patients achieve a goal in those with mutations. And these results were similar at the end of 1 year as well. A quick look at our Cascade experience with Cascade Screening. Of the 600 odd patients who are probands, I mentioned that nearly 200 of them had a mutation identified. Of those who had mutation identified, we offered Cascade Screening for the first-degree relatives. Only about 40% of our patients who are offered agreed to invite their first-degree relatives to come for Cascade testing. Of these 87 individuals, 193 family members came forward for testing. Half of them had no mutation detected, another half had mutation detected. Of those who had mutation detected, 60% of them were previously undiagnosed. Those who previously were diagnosed to have some form of hypercholesterolemia, you can see that their LDL levels remain pretty high, at still a mean level of about 5, despite being on treatment. This is a slide just to show the levels of LDL-C, compare the medications in those who had mutation detected and those without mutation detected. You can see high intensity statin use, only 6% of our patients had, even in those with the mutations, only 6% were on high intensity statin. And only 40% of those who we identified mutations were on some treatment, as I mentioned earlier. So showing lots of work for us to do ahead. So those were the data that I wanted to share from our FH Care registry. For this particular symposium, I also wanted to share with you our experience with PCSK9 inhibitors. And this was from my institution, a program which was supported by Sanofi and Amgen for us to use alirocumab and evolocumab in over 1 year duration in patients who had despite maximally tolerated statin and ezetimibe, LDL levels which were still above target. We had enrolled 21 patients and 9 of them had an LDL receptor mutation and 1 was a compound heterozygote. You can see our patients actually tolerated the PCSK9 inhibitors very well and achieved about 56% on an average, 56% LDL-C reduction with the PCSK9 inhibitors. To increase awareness, our team has been working very closely with the Singapore Heart Foundation and taking part in their public outreach programs as well. And this was in a photo taken in pre-COVID times, you can see, out in an outreach on one Sunday morning to increase awareness on the FH. Apart from outreach programs, our team has, the FH Care has also been actively involved, trying to increase awareness through websites. We are grateful to Singapore Heart Foundation for giving us allowing us to share our information on their website, including patient videos as well. And we also have educational material for healthcare professionals as well as the general public as well. So a lot of the work the FH we have done through our FH Care core team, as well as all the collaborators from the different public healthcare institutions in Singapore. And I'm very, very grateful for all the contributions from the different doctors from these institutions as well. So with that, I'd like to end my presentation. And I'd like to thank you all for your time and attention as well. I look forward to the question and answer session after this as well. Thank you very much.
Thank you, Professor Tavin, for sharing the wonderful work that you do and the collaborative spirit that you have fostered across Singapore. It is truly remarkable to see and witness. I'd like to introduce our third speaker for today, Professor Stephen Nichols. Professor Nichols will be talking to us today about enhancing the care of familial hyperlipidemia. Prof. Nichols is a world-renowned cardiologist and leads the Victorian Heart Hospital, VHH, due to open at Monash University's Clayton campus in 2022. A multiple award winner, Prof. Nichols has written more than 770 manuscripts, book chapters, and conference proceedings, and has raised more than $100 million in research funding. Since 2012, Prof. Nichols has been Deputy Director and Heart Health Theme Leader at the South Australian Health and Medical Research Institute, SAMRI. He is also Professor of Cardiology at the University of Adelaide, Consultant Cardiologist at the Royal Adelaide Hospital, and the Principal Research Fellow of the National Health and Medical Research Council of Australia. Prof. Nichols, please.
Hi, my name is Steve Nichols from Monash University in Melbourne, Australia, and I'd like to talk about enhancing the care of familial hyperlipidemia and really extend from what we've just heard in the last two presentations. This slide summarizes my disclosures. So what's intriguing is that in 1997, the World Health Organization really issued an important document where they acknowledged the importance of familial hypercholesterolemia as a highly preventable cause of premature chronic disease, which left untreated had the risk of leading to catastrophic premature cardiovascular events. And really that report served as a call to arms for many around the world to really dig deeper to try and tackle the importance of FH globally. Unfortunately, there's really been relative silence in many countries of the world with regards to FH. But in more recent years, I think we've come to understand a lot more about the prevalence, the ability to detect disease, the risk associated with the disease. And fortunately, we've been able to develop a number of important therapeutic advances that have enabled for us to be able to effectively lower LDL cholesterol in many patients with FH, which goes a long way in terms of reducing their cardiovascular risk. The question is, how do we put this all together to develop a really integrated model of care, which should be considered not just at an individual perspective, but at a health service level, so that we're able to identify more patients and families with FH, be able to integrate and implement effective therapies and other support measures in place to be able to effectively reduce their chronic disease burden. And what I'd like to share with you today are really thoughts from the FH Australasia Network Consensus Working Group, a group that really thought long and hard about how we integrate guidance for FH across Australia and really to kind of reflect on a number of the important elements that we considered were going to be essential moving forward. So when we think about an integrated guidance, it really does go the full way. It starts with phenotypic detection and index cases with implications for screening and testing. It talks about how we look for diagnosis and risk assessment. It looks at genetic testing, it looks at management, and importantly, it looks forward in terms of how we might want to organise our developmental models of care across an entire nation. So in terms of phenotypic detection, I think it's important that several strategies, selective, opportunistic, and universal screening, should be considered for use. We advocate for selective screening of adults who have premature ASCVD, have a family history of premature ASCVD in the presence or absence of a high level of LDL cholesterol. We advocate for opportunistic screening in anybody who has an LDL cholesterol greater than 5 millimoles per litre in primary care. Universal screening for anybody with an LDL cholesterol greater than 3.5 millimoles per litre in childhood. And consider the use of digital screening of electronic health records moving forward. We advocate that the Dutch Lipid clinical network criteria should only be used in adults and not in children and adolescents. In patients with a triglyceride level greater than 4.5 millimoles per litre, LDL cholesterol levels should be measured by a direct rather than calculated assay. In patients with a triglyceride level greater than 10 millimoles per litre, an FH diagnosis should be reconsidered after effective lowering of triglyceride levels. And it's important that all patients with suspected FH should be referred to or at least discussed with a specialist with expertise in the area. Now, what about diagnosis and assessment of FH in adults? Importantly, all secondary causes of hypercholesterolemia should be excluded. An FH diagnosis should ideally be made using both phenotypic criteria and genetic testing where available. Where it's not available, phenotype alone is acceptable. Imaging of features like tendon xanthometer certainly should be considered for diagnosis and risk assessment. When possible, genetic testing should confirm the diagnosis and aid cascade screening. And in all FH patients, we believe it's important to risk assess for the presence of other ASCVD risk factors such as hypertriglyceridemia, diabetes, hypertension, but also to include lipoprotein(a). It's important that standard cardiovascular risk prediction algorithms should not be used in FH patients. And imaging of subclinical atherosclerosis should be considered, although the clinical value of that approach is yet to be established in clinical trials. And then finally, all patients with homozygous FH should be referred to a specialist centre for clinical assessment and evaluation of their atherosclerotic cardiovascular disease burden. Now, what about in children? Again, it's important to exclude any secondary causes of hypercholesterolemia. We believe that children with xanthometer and or other features or at risk of homozygous FH should be tested early, and that's before the age of 2. We think that all children with suspected heterozygous FH should be tested between the ages of 5 and 10. And again, it's important to clarify that the Dutch Lipid Clinical Network criteria should not be employed in children and adolescents. A high probability phenotypic diagnosis of FH should be considered in children when there's an LDL cholesterol greater than 5 millimoles per litre, when there's an LDL cholesterol between 4 and 5 millimoles per litre in the presence of a family history of hypercholesterolemia or premature ASCVD, or where there's an LDL cholesterol greater than 3.5 millimoles per litre when there's a parent who carries a potentially pathogenic variant. Genetic testing should be offered to children when identified in a first-degree relative. Heterozygous FH children should ideally be reviewed by a specialist. All homozygous FH children should be referred to a specialised centre. And it's important that all similar ASCVD risk assessments should be made, although there's less evidence for calcium scoring and CT coronary angiography in this group compared with carotid IMT measurements. In terms of genetic testing and counselling should ideally be offered to all adult index cases. It should be considered when there's limited information available to calculate a Dutch lipid score. And it should be considered in children when first-degree relatives are either deceased or unknown, or as part of universal screening, or if it's required to access special therapies. Genetic testing ideally should be carried out in an accredited lab. And if a known variant is not detected, FH is not necessarily excluded if the clinical phenotype is strongly suggestive of FH. Polygenic risk scores have emerged in more recent years for both FH and for ASCVD. They can re-stratify, but their precise value in the setting of FH remains uncertain. Genetic testing should ideally be ordered by a specialist or a general practitioner with particular skills in the care of patients and families with FH. All healthcare professionals dealing with FH should have basic skills in genetic counselling. Simple and pragmatic tools for counselling should be developed to aid healthcare professionals, and preconception counselling should be considered in the presence or the risk of familial hypercholesterolemia. Now, what about cascade testing and risk notification? Again, this should ideally be carried out using both a phenotypic and genotypic strategy where possible. Variant-specific testing has been demonstrated to be more cost-effective than phenotypic testing when it's known. And when genetic testing is not feasible, the diagnosis of close relatives should be made with an LDL cholesterol value. It's important with regards to risk notification to consider local legislative and institutional guidelines for the notification of relatives, and it's always important to respect the principles of privacy, justice, and autonomy. Pre- and post-test counselling should be offered to all at-risk family members. And ideally, this should be carried out by either a specialist centre with expertise in FH or a general practitioner who has particular expertise in the area. The first steps are to initially prioritise first-degree relatives and then extend out as other carriers or cases are identified. Universal screening of children should be coupled in a reverse manner with parent testing. And then finally, I think there's an opportunity with regards to digital technologies and the ability to develop these technologies to assist our ability to more effectively carry out cascade screening and risk notification. What about the management of adults? So FH patients should be offered counselling on lifestyle and interventions to address other ASCVD risk factors and psychological issues. It's important that a management plan be personalised and based on shared decision-making, health literacy, and identified barriers to potential treatment non-adherence. It's important to aim for at least a 50% lowering of LDL cholesterol, and then to aim for different targets depending on what we think the ASCVD risk is. For the essential primary prevention patient, it's an LDL cholesterol less than 2.5 millimoles per litre. In the presence of either multiple CVD risk factors or the presence of subclinical atherosclerosis on imaging, it may be more aggressive, less than 1.8 millimoles per litre. And for the patient who's got clinically manifest ASCVD, ideally it should be an LDL cholesterol less than 1.4 millimoles per litre. That's going to be achieved by use of maximally tolerated statins in all patients in combination with a range of other lipid-lowering therapies according to the relative difficulty in achieving lipid control. For patients with heterozygous FH between the ages of 18 to 30 who have been treated from childhood, who don't have ASCVD, it's certainly reasonable to consider less intensive goals. There's some school of thought that low-dose aspirin can be considered in the asymptomatic patient at particularly high ASCVD risk. And all FH patients, particularly those at higher risk and older, should be offered the normal seasonal respiratory vaccines. All women of childbearing potential should be offered counselling and lipid-lowering therapies, should be stopped at least 3 months prior to conception and during pregnancy and breastfeeding. In women with homozygous FH who have ASCVD, it certainly is possible to use statins and ezetimibe after the first trimester, particularly if lipoprotein apheresis is not feasible. And then finally, there are a range of additional therapies such as lamidopide, evinacumab, and apheresis that could be considered for homozygous FH, and particularly those patients who have got progressive ASCVD. What about the management of FH in children? The shared decision-making not only involves the patient, but involves the parents and needs to be adopted and applied in a developmentally appropriate and inclusive approach. For children with heterozygous FH, we consider initiating a statin between the ages of 8 and 10, and to aim for an LDL cholesterol less than 4 millimoles per litre, or at least a 30% reduction in LDL cholesterol. Earlier treatment should be considered when the risk is considered higher, and the use of statins and other agents needs to be appropriate to their relative licensing in specific countries. For homozygous FH children, given the particular high CV risk we see there, we advocate treating as early as possible, and that ideally is by the age of 2 years. All adolescent girls should be offered pre-pregnancy counselling, and shared care of children between specialists and general practitioners is essential for their long-term management. And then finally, it's critical that we consider the transition to young adult services as adolescents become older, and that be considered early and planned in advance. And then finally, there's the concept of what do organisations have to consider in terms of development of care. It's important that we design and implement models of care based on principles of public health, precision and preventative medicine. Pathways need to be developed to meet the needs of local, regional and remote communities, and their acceptability to health consumers and professionals, as well as cost effectiveness and value, should be reviewed regularly. Care should be multidisciplinary, with access to lipidology, cardiology, endocrinology, pediatrics, genetics, imaging, transfusion medicine for apheresis, nursing, dietetics, psychology, pharmacy, pathology and telehealth services. Importantly, the general practitioner is central to the continuity of care of all FH patients and their families. Patients, in fact, who are well controlled and lower complexity can probably be managed exclusively in primary care. The development of national registries are essential, and it's important that we develop national coding systems for FH to improve data acquisition and linkage and their utilisation for audit, research and development of health policy. We need an ongoing research agenda for FH that spans population, basic and clinical research. It's patient-centred and ultimately leads to implementation strategies. And finally, and very importantly, it's critical that we continue to establish advocacy and support groups. I've reflected on the registries. A number of countries now have national registries, many of which are contributing to a global registry that is led by Imperial College London and the European Atherosclerosis Society. That is important in terms that continues to promote the awareness of FH. It provides real-world clinical practice evaluations. They contribute to our scientific knowledge. They inform our clinical practice guidelines. They enable implementation strategies, both globally and in specific countries. And ultimately, they have the potential to improve health outcomes. And so coming back to this WHO document of 1997, it really is important to consider the statements made then because they're just as important today. The prognosis for primary prevention of coronary artery disease in asymptomatic patients with heterozygous FH is excellent. And the major challenge for both healthcare providers and health plans remains the identification and effective treatment of those patients with heterozygous FH who currently remain undiagnosed and or inadequately treated. Education campaigns need to be established to effectively improve public and healthcare professional awareness of FH. A registry of FH patients, their affected and at-risk relatives, and associated physicians should be established in countries or regions in order to assist in case detection through family screening, education of patients and their physicians, and long-term follow-up. Because of their extreme risk, FH patients should be contacted at least annually to ensure their continued treatment and compliance. Finally, the ultimate aim is to have the government recognise its responsibility towards the population. The government is aware that FH poses a serious health hazard, that strategies for identification and prevention are available, and therefore should take action to implement these strategies in order to prevent, avoiding suffering and death. We have the potential to move beyond treating the individual patient to really tackling FH at a system-wide approach, and it will only be with integrated healthcare models of care that we'll be able to achieve that. I thank you for your attention.
Thank you so much, Prof. Nichols, for a wonderful talk. And it actually answered a lot of the questions that I had prepared for our Q&A today, specific to the pediatric cohort. So I'd like to turn the session over to Professor Tavin, who will be leading us through the Q&A.
Thank you very much, Natalie. And thank you very much, E Shyong and Stephen, for the excellent talks as well. Yeah, so we'll start off with some questions here. Maybe I'll just ask Professor Nichols first. For you mentioned about the diagnosis of FH, a phenotypic diagnosis of FH is adequate. In your practice, what do you do for a patient who is tested with clinical FH with a negative, with no mutation detected? So in terms of the goals, are they the treatment targets for LDL, are they similar? And also, do you proceed on to cascade the family members with lipid profiles as well? Thank you.
Yeah, so I think where I think there's a high suspicion of FH, the ability to not demonstrate one of the known major mutations doesn't really change my view. If the phenotype's there, I'm going to want to treat the patient aggressively. I say to the patient, look, we haven't found one of the major known mutations. That doesn't mean that there's not a mutation, and that we also know that polygenic forms of FH can occur now in terms of a combination of multiple kind of polymorphisms. And so particularly when I think that there was a high likelihood that the patient would have with FH, and I would still, in that situation, maintain that everybody in the family should have a lipid profile performed, because in the end of the day, it's the phenotype that's going to drive the management. And so I think that that's important. Where there was much less certainty, then I think that, if you really weren't certain, there wasn't a mutation, well, then perhaps it's a different discussion you have with the patient.
Thank you. E Shyong, you have anything you want to add as well?
No, I mean, I think I agree with Steve. I mean, I think one of the challenges, though, is, despite what we say about the fact that the mutation, the test is sometimes, the genetic test is sometimes a false negative, patients do perceive that they must be at lower risk. Now, having said that, even if we take less aggressive targets with these individuals, they will still see very often the 50% reduction that we would be aiming for. So, I think we need to treat them.
And following on that line, I have a lot of patients who are referred along where there's a presumptive diagnosis of FH. The patient has already commenced therapy. They're happy taking therapy. The family's already had their lipid profile done. And the question is, should they have genetic testing? And I actually don't think the argument's necessarily that strong for them to have genetic testing in that situation. And I say to the patient, look, the reason really for me to do genetic testing is if I have to convince you and your family to take this seriously. And if the patient's already taking therapy, already, as you said, seeing a really good lipid lowering response, I'm kind of lukewarm about pushing ahead with the genetic testing, because you get exactly this situation that could arise, which then confuses a situation. So I don't always order genetic testing in that situations, and patients are actually very happy with that, particularly if there's a cost involved with it. Now, in Australia, we've recently had a government subsidy for genetic testing for FH if you have at least a Dutch lipid score of 6. I have a lot of people sent to me on scores of 4 or 5. They'd have to pay out of pocket for testing. They're already taking the statin. So I kind of say, look, you can pay for an expensive test, but if you're already doing what I'm going to ask you to do, then save the money and take the statin.
Yes. Thank you. Yeah, in Singapore as well, we don't have genetic testing as part of the clinical options as well. So if clinically is very obvious FH, it's we will push for the same targets as well and goals. The problem comes that once we are doing the genetic testing and maybe 50-60% of the time it comes back to be negative, and supposing the person is already at goal, then I guess some clinicians might be tempted to be a bit, if they, like here, I think what you're saying is that without the genetic diagnosis here, you're already quite confident it is for this particular patient with FH, you're just going and treating as intensively as possible. When the diagnosis comes back to be, if supposing there was no mutation detected, doesn't mean it's not clinical FH. That doesn't mean it's not FH as well. Yeah. Sorry, you're going to say something else, Stephen?
No.
No, thank you. Yeah. E Shyong, you just as part of the different options for genetic testing, you mentioned universal screening as well. In someone with what would the recommendation for someone with a detected mutation for an LDL receptor, with supposing in a rare event that the LDL is not high?
Oh, I don't know what to do with those.
Yeah.
The penetrance of FH, I don't think the penetrance is 100%. I do think there are other things that can sort of modify these. Some of these, I think, are going to be misannotation of the variant, and maybe it's not pathogenic. I'm not sure what to do with those. I think we do struggle, but I do think we are guided by the phenotype. If the LDL is moderate, we know that these individuals are still at increased risk if they carry a pathogenic or likely pathogenic variant based on today's annotation. I think the real challenge becomes, if their LDL cholesterol is 2, and they carry one of these variants, then what is that? And I think that's a much bigger challenge.
You know, for me, I think that particularly for LDL, these are people who you probably are going to more frequently monitor, aren't they, in terms of lipid profiles? So, I will say to a patient about either their own levels or their families, particularly when I've got adult patients and they're talking about their children and their children being screened. And I will say, these are probably scenarios where you would probably do more frequent lipid monitoring over the years. I mean, we do know that, like blood pressure, there's a tendency in the community for LDL cholesterol levels to rise with age. And, if there's particularly if there's a mutation setting which hasn't quite expressed itself yet, it may simply just come a little bit later, and that is a good scenario to think about. Continuing to monitor. The distinction to that is, for example, a patient with an elevated Lp(a), where we know genetics is a really strong factor there. And when you ask those patients for their family members to be screened, their Lp(a) is probably not going to change. And so if their family members have an Lp(a) that's normal, you probably don't have to repeat that again. But with LDL, frequent monitoring is part of the game.
Yes, thank you. I asked this question because in our the group of the patients that we did as part of our research of the 600 odd probands, we had someone with a positive mutation. The family member was cascaded and was positive, but the LDL was like below 2.6 or so. It was in the early 20s or somewhere thereabouts. So that was a situation that we had. Yeah. We counseled him as if he was a FH, since the family member was positive, and clear clinical phenotype of FH as well. Yeah. The other thing that in the FH, the program that we have, the difficulty that we have with cascade testing, maybe I would just, I was quite interested in Professor Nichols, the comment about the risk notification letters in Australia that you do, because for our cascade testing, we are very dependent on the index patient to give us the information and invite his family members to come. And beyond that, we are unable to access the family. So you mentioned something about risk notification letters according to each country's legislation. So can you share with me?
And I think it speaks exactly to the point you just raised, which is that in most countries, there are privacy regulations that just prohibit just routinely reaching out to all of a patient's relatives. And so that's one of the inherent challenges with cascade screening is you really need the patient. You need the index case to go out to their family. They need to do the sales pitch. Then they need to bring the relatives kind of back to the table, and family dynamics are often quite complex. Not all family members talk to each other. In fact, some are quite estranged. And so it can be challenging, and we do have to operate within local regulations for how we can and cannot approach relatives, because privacy matters.
So your letters are delivered through the index patient, or is through the mail?
No, well, so what will happen is in most of our centres, the index will reach out to their family members and then ask them to, and then they will essentially come back to us with those details. That will then enable for us to then send a letter out. And if at the very least it starts by, the easiest recommendation is just to simply alert family members that this variable may be something that's in their family, and that they should at the very least see their general practitioner and have a lipid profile. At least if you start off with phenotype, as we've all said is ultimately the most important thing, then that's a good place to start.
So it's still very much dependent on how activated the index patient is and enrolled in. Okay.
Yeah.
Prof. Nichols and Prof. Tai and Prof. Tavin, now that I have all of you in one place, I'd really like to ask a question on behalf of some of the patients that tested positive as part of FH care. We picked them up because they were young, in the 40s, and they had an index myocardial infarction, and they turned out to be gene positive. Thanks to the moratorium that has been issued 6 months ago, their genetic data is protected, and they are grateful for that. However, many of them have young children, and a lot of the children are pre-adolescent, 5-6 years old. So I know that Prof. Nichols presented specifically the pediatric cohort for the Australasian network, but I'd like to ask all our panelists, from a, in general, how early should we start screening and treatment for the children of the index of the proband? What are the target levels for the children? And what are the drug safety and label indications when we counsel their parents when we want to initiate such therapy? When do we need to refer to a pediatrician?
So who's going to go first?
I'm happy to go first.
Great. Yeah.
So look, it's difficult and it's a moving target, and I feel that we continue to evolve our thinking about this, and a lot of it is done not necessarily based on evidence. So I think certainly my view is to advocate that children should be screened. Unless there's a family with homozygous FH or really catastrophic premature ASCVD in their 20s, I think it's okay to let most families wait until the children are about 10. I typically don't start treatment before then unless I've got a really aggressive form of FH or family history that really worries me. And then obviously you're going to have a conversation that's very much going to involve families. You're going to talk particularly when the adolescent is a girl, that there will be implications for coming off therapy, later on if there's a pregnancy or planned pregnancy kind of involved. I probably would use less aggressive targets early on and just get some LDL lowering, just to lower the area under the curve. In each country, I think it's important to look at what's approved for children and what's not. Not every statin is approved in every country. And so I think, you need to understand what's available in your country. And then we know more and more therapies are being tested in younger and younger patients because we need more options. So it really is it's about, I think there's a lot more flexibility early on with the principle that you do want to start, but you have to really tailor it to the patient and the family.
E Shyong, anything else?
No, I take a very similar sort of view. I don't push aggressively for genetic testing below the age of about 8 to 10. And the conversation that I have is, if this is your child, you would want them to have as normal a life expectancy as you can.
So very similar as well. I mean, with the program, FH care program going on, we have quite a number of families under our care as well. And the advice we've been given is similar, 8 to 10 years of age to offer for screening for genetic and the lipids as well. In terms, I think the younger, more aggressive FHs that the pediatricians are already treating, and they are using statin dose according to body weight, and they combine with different options as well. But I think those aggressive FHs are very, very difficult to treat as well. Yeah.
So I think we have to call time on this wonderful panel. Thank you so much, everyone for attending, and thank you to our distinguished speakers for their insights. I feel like I've learned more in the last hour on FH than I have in some time. Thank you so much for the robust discussion as well, and everyone who submitted questions. Have a wonderful day.
Thank you. Thank you all. Thank you very much.
Thank you.
Thank you for coming.